As we go through the course of our time together, and I think we have an hour, is that right? Okay, great. Let's make it a discussion, conversation. Raise your hand, ask questions. And I have a prepared talk, and I went back and took out about a third of the slides so that we would have more time for for discussion and conversation. And I need that. Okie doke. Great. All right. Ready? Here we go. I want to introduce you to Mrs. Buckley. Mrs. Buckley is 76 years old. She lives alone. She lives here in the Upper Valley. She's insured by Medicare. Can you see? I don't want to get in your way. She has emphysema, which you'll hear referred to as chronic obstructive pulmonary disease, COPD, congestive heart failure, and early signs of dementia. She never finished high school. She worked as a self-employed seamstress and had minimal savings at the time that she quit working. She used to smoke a pack of cigarettes a day, but quit over 20 years ago. She doesn't have a car. She stocks up on canned goods when she goes to the store, obviously, because it's hard for her to get back and forth to the grocery store. And 2 days ago, she ran out of her diuretic, her water pill, and she began to feel a little short of breath. Does anyone live near Mrs. Buckley or know of a Mrs. Buckley in their community? Pretty common, I think, for the Upper Valley. So, Mrs. Buckley calls her primary care physician and explains that she's a little short of breath, but unfortunately her internist is really, really busy. Here's her internist waiting room, and she can't fit her in today. So she says, "Oh, Mrs. Buckley, I'm sorry. You're going to have to go to the hospital. I can't meet you in the office today." So Miss Buckley doesn't have a car, so she dials 911 and calls the ambulance. And the ambulance takes her to the closest emergency room. And in the emergency department, Mrs. Buckley sees a physician she's never seen before. She's actually been, given all of her health problems, she's been pretty lucky. She hasn't had to go to the emergency department very often. And the doctor who sees her in the emergency department says, there's an abnormality on the heart tracing, the ECG. Actually, the truth of the matter is, folks, that was an old finding, but all of Mrs. Buckley's records are at another hospital, St. over there. She's actually at St. elsewhere right now. And so the physician in the emergency department doesn't have access to her old heart tracings, her old ECGs. So she's got shortness of breath, known heart disease, and abnormal heart tracing, and the emergency physician says, "I'm going to admit her to take care of her because I'm worried about what's going on in terms of her heart." So let's go back a little. So Mrs. Buckley gets admitted to the general medical floor, and there she meets yet another new physician who is a hospitalist. Hospitalists are the docs who spend all of their time practicing in the hospital. And he assumes, or she assumes, care for Mrs. Buckley. And an IV is put in and medicine is given in order to try to get rid of the extra fluid. And because that makes you go to the bathroom a lot and Mrs. Buckley is a little unstable on her feet, they put a catheter into her bladder so she doesn't have to get up all night long to go to the bathroom. But unfortunately, Mrs. Buckley gets an infection from that catheter. In fact, that is such a common infection, we have an acronym for it, a CAUTI, catheter-associated urinary tract infection. And the hospitalist notes that she's got a little fever and notes this infection, so she gives her an antibiotic. And the antibiotic is an antibiotic that Mrs. Buckley is intolerant to. She's not allergic to it, but it makes her nauseated when she takes it. And the physician wouldn't know that. The physician is aware of her allergies, but this is sort of nuanced medical information that he just, or she just didn't have access to, because remember, all the records are at the other place or in the outpatient setting. So Mrs. Buckley gets this antibiotic, makes her a little nauseated. She can't eat. She becomes weak and gets more and more confused as she gets weaker in the hospital. After an entire week in the hospital, she's too weak to go home. And so her son, who lives out in California, has to fly back, and they start the search for looking for a place where she can go to recuperate. So, did she get good health care? You said no. Technically, yes. Why technically yes?
Because everyone she met in the system did their best to treat her based on what they knew about her.
They did. They did. They did a good job, I think, given what they knew. But you shook your head no.
I feel like it kind of all fell apart when she didn't have the medication that she needed.
Oh. So, was that good health care? I mean, so she didn't have access, she ran out of that diuretic pill. That sort of started the cascade too. But in terms of health care, she was on the right medicine, so.
She didn't have access to her PCP, who probably could have just refilled the prescription.
She didn't have, sorry?
Access to like her PCP.
She didn't.
Probably could have just refilled the prescription for her, and somehow, I'm not quite sure how, that's an issue. She could have gone to refill it.
So if she had gotten her diuretic on time, we could have probably avoided this. I think, yeah, possibly. What do others think?
Into her primary care, that whole situation could have been avoided if she'd seen people that were familiar with her case.
Right. So if she had gotten the medicine, gotten the refill automatically, if she could have gotten into the PCP office quickly, does she have a bad primary care doctor?
Oh no, they're probably just inundated with patients.
They're inundated
So
with
they
patients.
don't have the ability to see as many as they can.
Yeah.
You know?
Why are they so inundated with patients, all these primary care doctors? Why are they running their office like that?
Aren't the insurance companies squeezing the system to try to maximize profits?
Well, someone's got to pay the bills, right? So that physician is booking a lot of patients, and the squeeze may come from the reimbursement to the physician not being adequate to keep that office going. So instead of seeing fee-for-service, this is fee-for-service, so I'm getting paid in a system where I'm getting paid for each patient that I see. If the actual amount that I get paid per patient is not very high, the only way to respond to that is to see more patients. So I need to see more and more patients in order to pay the bills and pay my staff and keep the electricity on. So where the squeeze actually happens is probably in multiple points along the way. But the response to the lower reimbursement is to, or the higher cost of operating, are to increase volume. So the doctor is good, but is forced to run a very busy practice, right? Please.
Like maybe if there was some kind of streamlined way for information, like, I don't know about HIPAA or anything like that, but if somebody could go in and, type in someone's name and all that information could come up, like we already know about this illness, we know that she's sick with, this medication makes her sick, or some kind of better connection, I guess, where it's not creating this domino effect of.
Right. So that the lack of flow of information certainly contributed to this story, didn't it? So we have a system that wasn't very proactive. In other words, we didn't know that she needed that refill, or if we did know, nothing happened. We had Mrs. Buckley couldn't get into her PCP because she's running as fast as she can, seeing patients every 15 minutes in order to pay the bills. We have a lack of flow of information. So everyone was doing the best they could technically, but when we added it all together, it wasn't turning into a good health care outcome. Please.
I still have this emphasis on prevention. So I'm thinking that if a son is in California and he knows his mother is in the stages of early dementia, he should have a neighbor, a friend, someone in the community that can check in on her so that she wouldn't have run out of her medications, and she wouldn't necessarily call an ambulance. She could call this friend, who could then run to the pharmacy in the next day or so and pick up her pills, and then none of the expense and trauma of the hospital care. And I mean, if anyone's been to an emergency room around here recently, you're 6 or 7 hours in the waiting room before you even get in the back into a bed, and then it could be a couple of hours before you see a doctor. It's just, they're overtaxed, even here where we have a level 1 trauma center, and in lots of communities, there's no medical center like that.
So again, highlighting the proactive part, if we could have prevented instead of reacted to, similar to your comment about how come the refill, why didn't she just get her refill? So let me ask you, so let's not be mean to the son. I mean, he's working as hard as he can out there in California. Who does he call if he wants to have someone check in on mom? Like, whose job is it for him, for someone to be doing that proactive, let me check and check on you?
I'm gonna say I was the son with my dad for 10 years. I didn't know anybody in Albuquerque. I didn't know who to call. There was no one for me to call. I didn't know phone numbers for my dad's neighbors. He didn't give them to me.
You're a bad daughter.
Terrible.
No.
Terrible. But there's no one to call. You
There's
don't get
no
a
one to
social
call.
worker until you're already in the system and everything's already cascaded. You get a social worker when your dad's in hospice care across the country.
Right. So I agree with you. It'd be great if we had someone to call, but who are those people to call? When you need a visiting nurse, and there's a set of criteria for what qualifies you for a visiting nurse, you'll know who to call, the visiting nurse. But whose job is it just to check in and see, hey, Mrs. Buckley, how are you doing? Can I get you to the grocery store? I noticed that your pill bottle here is empty. How can I help you?
Yeah, I do house cleaning for several elderly women who can afford to pay me $30 an hour, so they're not, they're doing pretty well, and they have no one to call. None of their family lives nearby. I end up, as a house cleaner, often going to the grocery store, doing stuff around the house. I probably see them more than anybody else does. I see them every 2 weeks. I probably have a better, bead on what's going on for them health-wise than anybody else in their lives does. And that is terrifying to me. Like, that's not how it should be. But even for folks who have enough money, that's how it is right now.
So
Why
isn't
couldn't that be a job for someone who didn't want to clean houses, but who checked in on people on a regular basis?
it sounds like a great job. Who's going to pay for it?
The person who gets the services.
Mrs. Buckley had minimal savings at the time that she retired. She doesn't have $30 an hour or any extra money.
Well, does Medicare pay for all of the ambulance service and all of the hospital service, and then there's all the nursing home costs and?
Sure, those are healthcare costs. Our insurance system pays for the healthcare costs. So isn't this interesting that we're talking about, did she get good health care? And all of a sudden, we're talking about where are her friends? And I have, the wealthy people or the people of means who I am providing support to, either cleaning their house and probably checking in on them. The wealthy friends that we have are getting a different set of supports. And I don't know who the neighbors are. We started talking by healthcare, but look at what we're talking about. And that is the next set of questions. What impacted her health? Not her health care, because I agree with you. I think technically she got very good care, but somehow it didn't fit together. And more importantly, when we take a step upstream and start to talk about health and what determines Mrs. Buckley's health, we're talking about a whole different set of factors, not prescription drugs, not catheters and bladders, not emergency departments, but isolated. I don't know what neighbors to call. No one is proactively checking in on her. So let's think about, through the course of our discussion today, what is the difference between health care and health? To talk about the fact that exactly what you were saying. All this expensive emergency department, the ambulance, the nursing home, all these things that we pay for and are really expensive, and to the point of getting the squeeze here, the rising costs of delivering health care services is threatening the communities where we live. And then we're going to spend some time talking about your job as physicians in your communities, as healers in your communities, what your job is, what you can do. Much of what Barbara said as you're thinking through every single presentation today, what can I do starting next Tuesday to make a difference? So what's health? A state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This is very different than saying health is my A1C level if I have diabetes, or the number of vaccines that I received, or how well my heart pumps. This is really a holistic definition of what health is. And the reason that I make that distinction between health and all these other clinical markers that people talk about in terms of how good is your health. Oh, my diabetes is under control, my A1C is. We just looked at Mrs. Buckley, who technically got good health care, but all of us agreed as we were talking, her health, she came out of that hospital worse off than even before she started.
Some make a distinction between health and wellness, but it seems to me that this definition integrates wellness into the definition.
Yes, I agree. And I don't have a good definition for the difference between health and wellness. I kind of put those well-being and health, those concepts together in contrast to healthcare services that are delivered.
Just the date, that was 1948, that
Isn't that amazing? Yeah.
Yeah.
It's incredible, isn't it? These are not new concepts. So what determines health? We all talk about the 80-20 rule. So I would say for health, the 80-20 rule holds very well here. 10 to 20% of what determines health, again, that holistic definition that we just looked at, that sense of physical, spiritual, and mental well-being, 10 to 20% is impacted by your health care services. 10 to 20%. That's not very much. 80% of health is impacted by your socioeconomic status, the people who can afford to pay $30 an hour to have someone cleaning and checking in on them, their health behaviors. Remember Mrs. Buckley? She had COPD, emphysema, as absolutely, and probably her congestive heart failure as well was due to her smoking. She had a long history of smoking, so our health behaviors. And about 10% in this equation is due to your physical environment. Where do you live? And I'm not only talking about the quality of the air that you breathe or your water, but do you have a safe place to go out and exercise? Or when you go outside, do you worry about getting shot on a basketball court like Chicago, and parents who can't let their kids go outside, they fear for a drive-by shooting? So health behaviors in this model, and this model comes from the University of Wisconsin, where health outcomes are how long do you live, and what is the quality of your life, what is the quality, your sense of well-being, of health, of mental and physical and spiritual well-being. And health behaviors account for 30%, clinical care 10 to 20%, socioeconomic factors 40%, and physical environment 10%.
Could you speak briefly to how race and other pieces of our identities play into some of these health structural determinants?
So we know that, and I don't think I have any slides left. I don't think I kept them in here. We know absolutely that race there are differences in health outcomes for race even when we correct for socioeconomic status and education, a lot of the difference in race is due to the socioeconomic status. But even when we correct for that, there are differences.
Especially in clinical care, as we're increasingly finding.
Yeah, in clinical care and in outcomes. And so where the clinical care and genetics or unmeasured impact of factors that we can't even explain yet, it is complicated. But there's no question that race plays a difference. I didn't include that, but can certainly bring some information or send it to you. So let's talk about the social determinants of health. You hear this, who's heard this term before? This is really that 80-20 piece. This is the 80% piece. The social determinants of health are the circumstances in which people are born, grow up, live, work, and age, as well as the systems put in place to deal with illness. So it recognizes the healthcare service part of it, but it's really focused on those socioeconomic and health behavior factors that impact health. These circumstances are in turn shaped by a wide set of forces: economic, social, policies, and politics. This looks like a huge, it's sort of overwhelming, right? And remember, I'm going to come back at the end and ask each of you, how do you make an impact here? So it's starting to look a little bit overwhelming, but on the other hand, all of you fit in somewhere: policy, economics, shaping behaviors of the educators in our room. So we're going to keep this at the forefront as we move through this discussion. So let's go back to Mrs. Buckley. And remember, we talked about the social determinants of health. And let's look and see what her social determinants of health, how they impacted her health. She lives alone. She never finished high school. Education, how does that impact health? Her wealth, we've already touched on that a little bit. Let's look at that some more. She smoked. She didn't have access to a car. And she stocked up on canned goods. What's the problem with canned goods when you have congestive heart failure? Salt. Yeah, exactly. Social isolation. Look at these. This is stunning to me. Social isolation, loneliness, and living alone. So loneliness is, it's the distress of between where I would like to be socially, the social support that I would like in my life, and where I am. Some people live alone and are not distressed by it, right? But that sense of loneliness creates distress and stress, and that sets in place a cascade of inflammatory physiologic changes in the body that certainly impact health. And look at about a 30% impact on death, on likelihood of death from social isolation. If you told me, Dr. Kraft, I'm going to give you a therapy that's going to make a difference, I can reduce preventable mortality by 30%, I would say, my God, that's incredible. That's an enormous impact on health. Look at this. This is a factor that impacts 30% on mortality, and I would challenge you in this room that each of you could probably make a difference without spending millions and millions of dollars on creating a new surgical therapy or a new drug. You, in your roles in the community, you can probably make an impact on social isolation. Rachel.
So there's the push for aging in place and allowing people to stay in their homes alone for as long as possible, and this seems to make the argument that communities like the Woodlands might make a difference. I mean, is there something about the push in the one direction when the
there was Mrs. Buckley alone, and I think there are lots of people who live alone and are socially active and are supported and aren't at risk for the kind of cascade of events that happened to Mrs. Buckley. But we could have a discussion. Was that the best place for Mrs. Buckley? Was she safe the way she was living? So I don't think it's an either or. I don't think it's you have to be in a facility where there's lots of social interaction, or you're completely on your own. There's going to be a wide range of people who can live independently and yet not have to struggle with some of the health issues. I will say the number of times, people who when I was taking care of patients, and I had patients who were living alone like Mrs. Buckley, and it got to the point where everyone was concerned about safety, and we said it's time to move to a facility where there's more people who can provide care. There were many, many patients who they started to eat again, became much more awake and alert and interactive, and you could see that it was that social isolation was really, really lifting their spirits. So not either or, but I think that there are really good opportunities to also provide social interaction without having to move to a nursing home. And the Dartmouth Aging Resource Center is a great example of a place like that. Please.
Yeah, and I just wanted to add briefly that part of the Aging in Place program is things like home shares, where you can match people who are younger with people who are older. They can live together. Thereby, I think we talked about it in the last session in terms of housing.
Yeah.
That's one small option that actually two birds.
Yep, great. Please.
But to me, the dilemma is that if you take away Mrs. Buckley's stubbornness and independence and what has kept her alive her entire life by intervening and saying, sorry, you got to go to blank blank terrace, she's going to either resist and say, no, you're not, or she's going to begin to fail.
She might, but we
But
may
she
be
could
able to
also-
get the neighbor to come in and just check in and figure out some way to get her a little bit more support, a little bit more interaction. It's hard, and it has to be an individualized plan that works for each person. But I do think I think the take home from this is just this concept of being alone or loneliness, the distress from being in a situation where you wish you had more interaction has a real impact on mortality. Let's take one more and then we'll keep going.
I think the fact is that, a lot of people like Mrs. Buckley and many more couldn't begin to afford to live in a place like the Woodlands. But they might be able to attend a senior center
Right.
activity if they had someone in their neighborhood who could provide transportation. But the problem, when someone starts to have dementia, the situation of living alone, I know I had a neighbor once, a couple his mother lived with them. And one day she just went out and walked down a block and got on the bus and then got off the bus.
Yeah,
Like 5 miles down the road, and they came home from work and she wasn't there.
yeah.
And they had they found her and she was okay, but they had a devil of a time figuring out, and she didn't know where she went or why she went there. She just saw the bus and she walked down and got on.
Yeah, early dementia is hard. It is very difficult. Let's keep going because we're going to have a lot more opportunities for you guys to be physicians in your community. I highlight this slide. It's a little bit complicated, but I think there's a really important message here. The security of having a home or the security of having income so that you can pay for your home cannot be minimized. So the very bluest bar here on the most right-hand side is actual homelessness, no home. But there's a spectrum between homelessness and living in your home and being able to make rent without or pay your mortgage without any problem. People who move a lot or you're behind on rent, those are symptoms or might be symptoms of housing, what we call housing insecurity. And the highlight of this graph is it has huge impact on health. So here's having a child in the home with who's reported to have fair or poor health. So if you have a higher score, that's worse, right? You want lower scores. And look at what happens when you are behind on rent, multiple moves, or homeless, compared to a stable home. The children suffer. Here's the mother who reports fair or poor health. Maternal health is impacted, maternal depression, food insecurity. And look at these food and energy. In all of these cases, there is an impact on your ability to pay your rent and secure home and putting healthy food on the table or paying your utilities or making trade-offs with health. So it's not the house is making me healthy. It's having a home is a marker for a economic security that I have food and I have energy and I don't have to make a decision of paying the rent or getting that prescription medication. So these things are all tightly interwoven. Education. Mrs. Buckley never finished high school. If this is a self-report of your health status. Again, high is bad in this graph. If you have no high school diploma, over a quarter of the population in this survey who hadn't finished high school reported poor or fair health. In contrast to having a college degree, where it's only 6%. Again, it's not that when I got my college degree, I just was given, oh, you are now a more healthy person. What this does is it introduces a world of a better job, income security. I don't have to worry about where I'm going to sleep at night. I can afford to go to Whole Foods, actually not here, but the co-op and get vegetables. I don't have to go, I have a car, so I can go to the co-op every single day. I have a car. This relationship between education and health is what's highlighted here. So this is how I feel. But look at this one. This is mortality. The more years of education that you have, the all-cause risk of mortality decreases. Mortality. And the difference is for men and for women. Mortality is impacted by your education. How much money you have, your wealth or income. 1980, the disparity, this is your life expectancy, so that when you're born, how long can you expect to live, right? We know in 1980, even back, way back, this goes way, way, way back through history, if you're poor, when you're born, you won't live as long. The expectation is your life expectancy is less compared to the richest. And look what's happened over time. And this growing disparity between the rich and the poor, or the educated and the non-educated, or the homeless and those who have a home, these disparities in outcomes have increased over decade, over decade, over decade. Again, this is not the healthcare system. I can't, as a physician, write a prescription to eliminate disparities. This is something that you all need to be helping the health system work with, and we're going to get into that. I think this one is the one that really makes me gasp. This is infant mortality, so the mortality rates within the first year of life after you're born, rich, poor. Even on day one, there's a difference, a discrepancy between income mortality. But look what happens over 1 year. This disparity, these health inequities, I think threaten the fabric of our communities. Again, I can't write a prescription for this. I can't do a surgical procedure to fix this. This is something that you all, as leaders in the community, need to be knowledgeable about, and we need to work together on.
I just wanted to mention too that it's not between races, that gap in infant mortality is massive also.
It's massive also, and it doesn't correct for education or for wealth, which is what scares me.
Right. There are elements in our culture that are impacting mortality rates of infants and mothers depending on what color your skin is.
Exactly.
That are connected to income and wealth, but also in addition
Independent. Yeah. Transportation, I think this is something we see a lot in the Upper Valley, the challenges of transportation. This is from a study in rural New Mexico. Public transportation in rural areas has the potential to remove a physical barrier that prevents residents from accessing goods and services. Those goods and services being access to health care, education, or economic. I'm able to get to my job. So what about health care? Because I said that this was only 10 to 20% of the equation. So, like, should we even pay any attention to it? Well, yeah, we should. First of all, you all need to know, and you probably do know, that our United States healthcare system is not very effective in producing good health outcomes. And people, this is really sort of sometimes very shocking. But when you look at, when we compare the United States to other developed countries, so other countries like us, I'm not comparing us to sub-Sahara Africa, United Kingdom, Australia, Austria, Netherlands, New Zealand, these are all, you know, countries that look not dissimilar to the United States. Lowest performing, the United States. And these are on different measures of health, like life expectancy. Did you get the right health service when you needed it? If you had gotten all the right health services, could we have prevented a death?
Is that graph illustrating per dollar spent?
No, this is just performance. But you just asked me about per dollar spent. So let's look at how much we spend. The United States spends 50% more than the next most expensive country, and we have always been spending more. This is not something that just happened over the last couple of years. We have always been above the other developed countries, and our rate of change continues to increase year after year after year, our healthcare expenditures. And, you know, if you buy a Lexus car, you expect to get a certain quality, right? I mean, you make a decision. Am I going to spend, I don't know, how much does a Lexus cost? I don't know, $35,000? I don't know. If you go to buy a car for $35,000, in contrast to, I went to the want ads and I got a used car for $3,500, you expect some difference in that quality. Typically, in a consumer good, you spend more, you get higher quality. But look at, here we are. We spend way more than any other developed country. And this is just looking at life expectancy. And I can put up, in fact, let me see. I can put up graph after graph after graph of health outcomes. This is infant mortality. This is the United States of America. The United States of America. And yet we're spending way more than any other country. So, now there's some sense of outrage, I hope, amongst you. And the question comes forward, how can we possibly be spending so much on health care, and yet when you compare us to other countries, our health outcomes are not very good? Go back to that complicated graph we looked at from Wisconsin. It's the 80-20 rule, right? We spend a lot on the 10 to 20%, the health care services. But we're not spending as much on the other social determinants of health compared to other countries. Little complicated, but let's take some time and look at this one. So this is overall spending of health services and social services. The blue bar is health care. And, oh, guess what? Here's the United States. We already looked at this, right? We spend a lot more than other countries. When you look at the green bar, look at, our green bar is tiny as a percent of our total spend. So it's like, this is not rocket science, right? our 10 to 20%, our healthcare services, we're shelling out a lot of money for that. And I got to tell you, you know, I've been up here saying, oh, our health outcomes are not as good. It is true, our health outcomes on aggregate and many of these measures are not as good, but the United States is better than many places in many of the high-tech, like cancer care. We provide good cancer care. If you get cancer, come to the United States. We provide good cancer care. And there are other technical surgical procedures that we do here probably better than anywhere else. But when you look at the overall picture, the overall equation, that's where our health outcomes suffer compared to other countries. And this is the reason why. We are investing in that portion that only is accounting for 10 to 20% of health. Question?
Very confusing because my son is a doctor at Mass General, and his particular division is involved in dealing with foreign countries who send their wealthy patients, frankly, to the United States for care that they can't get
Right.
anywhere else. So there's that, the care is better here than anywhere else they could go. And then there's a certain percentage of the population in our country that is absolutely against government interference in their lives, and they don't want social services, they don't want, you know, how, when you have that percentage of the population that doesn't want that, how do you invest more in it?
I don't know. You guys are the question is, how do you start to address this, the fact that we're spending, we do have some of the, I agree with you, we have some of the best technical and healthcare services that the world can deliver. Look at, you know, just like you said, the wealthy people from other countries come here. Go up to Mayo at Rochester. It's fascinating. It looks like the United Nations. People from all over the world go to Mayo in Rochester to get the best care that the United States can offer, or Mass General, or you know, any of these big health systems. But that's not where the investment needs to happen if we want our overall, our brothers and sisters here in the United States, our Mrs. Buckleys, to get the best health care. So let's come back to that, because I do think that the answer lies in this room. It's not going to lie with Sally Kraft at Dartmouth-Hitchcock.
Just a question on the definition of dollar spent. So, you know, you had the developed countries up there as well. I'm assuming that includes government spending
Yep.
as well. Does it also address the fact that, you know, many people in Europe now are developing private health care because the socialized system's not working? Is that included in those?
So that's a good question. I'll have to go back and look. My understanding of this article is that it does do an estimate trying to combine both private and public spending.
Okay. Yeah.
But you're right, there are many countries that have dual systems.
Yeah.
The public system for everyone, and then the private system. If you're really interested in this story about international health care, there's a book by T.R. Reid, R-E-I-D. It's called The Healing of America. It is a great book. It's really easy to read, and it was a great book to help me understand the differences internationally.
Because the reason I ask is because, you know, being in the healthcare space and understanding the space very well as well, I think that, you know, sometimes, depending on no matter what your view is on ACA, right, that we think socialized medicine is going to solve all of the broken
Right.
healthcare issues, and that's really not the case.
So
Because many systems are going to this dual system now. We have a dual system as well, but particularly in Europe and some of those developed countries.
Right.
So I don't want to get you off track.
Yeah. But
Interested.
I think exactly what you said. We could become Medicare for all, but the only reason that's how that is going to promote health in the United States is if we can decrease the blue bar and increase the green bar. That's what I'm trying to impact. Health is only 10 to 20% of health care. Where we're getting squeezed is our blue bar here is getting bigger and bigger and bigger every year. The pie, how big this whole graph, this whole bar is, our wealth as a country is not growing as fast as the cost of healthcare. I've got a better graph that does this. Let's keep going. And so here, this is exactly what we've been talking about. And here's the graph. As we go through time and go into the future, this is our overall gross domestic product, right? How wealthy are we as a country? How much money do you make every year? Is it getting bigger and bigger, okay? Social Security, we're going to pay. Let's keep paying for this, please, everyone. But look what's happening. It's the health care costs are getting bigger and bigger, and they're squeezing out all that other spending. Our education, do we have money to create a bike path? Because we all know that we should be out and physically active. Access to, can we give a tax break to a grocery store so that it can build in an area where there's a food desert? We can't make those kind of investments. Those are the ones that impact 80% of our health. We can't make those investments if we are spending more and more and more on healthcare services. There's a squeeze here. I can't fix that squeeze. You all in this room probably have a better opportunity to fix that than I can. Let's just do a tiny bit of New Hampshire data, and then let's talk about what you can do by next Tuesday to get started. I don't have the answer. You're going to have to figure that out. Okay, so overall, New Hampshire is actually a pretty healthy state. We're number 11 out of 51 when you look at those bubbles that you can't see, I can't see, are all the different states. So there's a way to rank how you're doing healthcare-wise, and we're pretty darn good up here. Yeah, I'm pretty proud of that. I don't know. Vermont's up there. I don't know. I'll have to find. I can't see it from there. I'll have to look. Maybe on the. I'll look on the computer. So overall, number 11, pretty good, not too bad. But look what's happening. We're dropping in rank. This is our current rank. Our current rank is actually based on old data. This is poor Barbara. Barbara and I work with data sets that are like about 2 or 3 years behind. So we're always going, well, we're not quite sure where we are. But take it as it is. Comparing 2012, 13 data to 2015, 16 data, we're dropping in many of these different areas. Access to care, prevention and treatment, affordable, healthy lives, disparities. This one really makes me nervous. This is that difference between the haves and the have-nots. And this disparity in New Hampshire, we are ranked 35 out of 51. We have a lot of inequities. And I don't think it's hard for any of us to think. You see them every single day. Just drive south 20 minutes, 30 minutes. Kirsten can tell you there are enormous disparities.
Isn't that metric incorrect, though? This disparity is sort of the opposite of prevention and treatment. It's something you don't want. So it says 35 and then it says -5.
It,
Shouldn't it be +5?
it's getting low. It is getting worse. Yeah.
So if
Yeah.
it's increasing, it should be +5, I would think, instead of -5.
Yes, but it is dropping, but you're right. So yeah, it's increasing, right. Overall rank, we have disparities across our counties. We're not all the same. This is looking at sort of your overall, how long do you live? Actually, we'll look a little at a little detail here too. It's looking at how long you live and then how healthy did you feel during those years of life. Here's some detail. Hanover, average life expectancy 85. Newport, 75, 76. What's the distance from Hanover to Newport? 20 miles? I don't know. 30 miles? 10-year life expectancy difference. That's, I mean, that like takes my breath away. Sorry, can't hear.
In my organization, we've been working a lot with the rural piece. So I'd be very curious if it's actually, if the Newport being a more city-like area, what it would be like if we looked at Grafton, New Hampshire, and what those numbers would be. We're finding that there's so much less access to services for people who are in the rural areas.
So the issue of rural health, we do know that there are, to be poor and black, to be poor, black, and live in a rural environment is far worse than to be poor, black, and live in an urban environment. I think it's really complicated. You mentioned access to services, but also when you look, well, in fact, let's look together. This is highlighting that relationship between wealth and life expectancy here. But let's look at this. So when we look at even specific health metrics, we see enormous variation. This doesn't account for urban to rural differences, but I can tell you that I know that when you look urban to rural, you'll see these kind of discrepancies and metrics. A twofold difference in teenage pregnancy rate, and maybe 30 miles apart. I mean, not very far. We could all get in our cars and drive there pretty quickly. Smoking. We all know the incredible number of health impact, the incredible impact of smoking. We see enormous differences in small areas. So I think to your point about rural, we see differences in education levels, in income levels, in health behaviors, as well as access to services. And then I can't end this section without talking, of course, about the opioid epidemic. This is a just number of deaths from drug overdoses in New Hampshire. Enormous increase, you all know. You read it every single day or hear it on the radio. Here we are, little New Hampshire, number 11 in health overall in the United States, but we have the third highest overdose rate. Our communities are being ravaged by this disease entity. Again, this is a disease entity that I would say we could do it perfectly well. If you come to the clinic or the health system, we could be perfect. We're not. We could be perfect and still not be able to make the change that we want to change. This is a disease that's going to require all of us as community members to address. So, I don't mean to be a Debbie Downer. This was not supposed to be like, oh God, it's just before Christmas and I can't celebrate this year. I actually think all of this bad news is actually really good news. And the good news is that we started with the 80-20 rule. 80% of health is not due to health care. It's not due to what I do to you when you come to the clinic or the hospital. It is what you all are doing in the communities. Your educators, your bankers, you are nutritionists, you are community members who are checking in on their neighbors. You're raising children. You're reading to children. You are doing things every single day that have a big impact in health.
Well, you're voting.
You're voting. Well, yeah. Policy is important. We know that increasing our spending on health care, the expensive part of the health equation, the 10 to 20%, we are spending lots and lots more dollars as a country, but we're not getting healthier. So we don't need to spend, I would postulate, we don't need to spend a lot more on health care. What's our challenge? And I think that there's real hope here. If we know that spending more on health care isn't going to give us better health outcomes, but we know that the investments in what you do on a daily basis is going to make the difference, either small or big, or the votes that you cast when you go to vote. We've got a chance to really make a difference.